All right, and hello. This is for Chapter 10, which is all about capillary puncture equipment and procedures. All right. So here are some of the competencies. We're going to learn how to do all these wonderful things and learn all about this other stuff. There's quite a few here, okay? You got some objectives. All right. So when we are talking about capillary punctures, some of the other ways you might hear these referred to are dermal punctures or skin punctures. You'll also hear it called fingerstick or heelstick. This is where we take drops of blood by puncturing the capillary bed, which is in the dermal layer of the skin. Hence the terms capillary stick or dermal stick. Okay. We especially like to do these for pediatric patients. We use a lancet, which is a disposable, usually disposable, little itty bitty needle that just quickly makes a little puncture or a small little incision. The OSHA requires the blade to permanently retract, so it's like you press the button, it goes pa-ching, and it pops it out, pops it back in, and it makes a quick little cut. And we collect the blood into micro collection containers. You'll also hear these called microtubes or bullets because they're kind of bullet shaped. They are the exact same tubes that we use to collect blood in the large size tubes. They're just measured in microliters, but they have the same color coding, the same additives and all that stuff. It's just for smaller amounts of blood. Excuse me, sometimes we might collect blood from a syringe and it's a difficult draw and we're not getting a lot of blood, so we might then place it into one of these microtubes. We have to label those special that it's venous blood, otherwise they're going to assume that microtubes contain capillary blood. And the thing that's important to know about capillary blood versus venous blood versus even arterial blood is that the reference range for what's normal values for, say, glucose, potassium, and all those other things vary depending on what kind of blood it is. And when we talk about blood and stuff like that in Chapter 6, this will make a lot more sense. But just know for now that the reference ranges, what is a normal reference range for venous blood is going to be different than it is for capillary blood. So if you put venous blood into a capillary tube, you have to make sure that that is clear. So here's a picture of all the equipment. They're lettered, but only kind of. So oops, I went too far. Hang on. You got up in the left-hand corner, you got different types of lancets, even a laser lancet in there. On the upper left, you have all different kinds of microtubes. And then the bottom center are also lancets, but those ones are generally going to leave more of a incision rather than a puncture. And they're used usually for heelsticks where you need a little bit more blood. So we also have micro hematocrit tubes. Excuse me. But we don't use those very much in class. They fill by capillary action. We'll play with them a little bit just to show you, but we'll read more about those in a few moments. I can't right now. Sorry. Capillary blood gases. They don't really do those very much. More often than not, they're going to do an arterial blood gas. We don't generally collect those as phlebotomists. Most of the time, your respiratory therapists or your nurses do that, so we don't really train in that. But you can read about the procedure and all of that in the book. Slides, we're going to have a guest speaker come in from the MLT program, and they're going to show us how to make blood smears, which are used for manual differentials, which is part of the CBC test, a complete blood count test. It takes a lot of practice. I'm terrible at it. Of course, I don't do them very often, but we will talk about this a little bit. When she comes in to do this demonstration, that's when we'll really focus on this. So we'll focus on this more later on. All right, so when we're doing a capillary puncture, we definitely want to warm the site. And we can use a heel warmer. It's like the same thing you might hear, like a hand warmer that like hunters use, same kind of thing. You can also just grab a wet towel and put that on. In lab, a lot of times we'll take a glove, we'll turn on the hot water, and we'll fill up the glove like a water balloon and use that. We just want to make sure the water's not too hot. It's really good for like people that have really cold fingers or feet, but it's always going to increase the blood flow by as much as 7 times. So I put heat on everybody's site when I'm going to do a heel stick or a finger stick. So capillary specimens are made up of a mix of arterial blood and venous blood, and that's what makes up capillary blood. It's also got some fluid from within the tissues, the tissue space between the cells, and from the cellular fluid. It's really more closely resembles arterial blood, especially when we warm the sites. But And I think I have a graphic in this slide that'll show you that. This is another reference to the reference values. So for instance, glucose, potassium, they're normally higher in capillary punctures than venous blood, whereas calcium and sodium are generally lower in capillary blood than in venous blood. So you can see here some examples of that. When do you want to do a capillary puncture? You want to do it for older children and adults. You would want to do that when they're big veins that you can more easily access, have to be saved. Sometimes you'll have a patient that like the doctor is going to do chemo on them and they'll say no venipunctures from any of these veins, and they'll list off like every vein, because they don't want anything to potentially happen to them because they need them for chemo. This person's life depends on getting that chemo, so they don't want to not have those veins. So they'll say no venipunctures. So then you would have to do a finger stick. Maybe you've already done several venipunctures, and you can get the blood with the capillary, so let's do it that way. Maybe they don't have any veins. Maybe you're doing point of care, which we haven't talked a whole lot about, but like a glucose test on a glucose meter, that's point of care. You can just do a finger stick for that. You also can do it when someone is very, very anemic and they can't lose a lot of blood, which is more often than not the case with infants and young children. So we'll do, because we only need a smaller amount of blood, we can do a finger stick. We do newborn screenings, which you'll hear called PKUs. We do that via heel stick as well. Certain tests cannot be done on a capillary, which an ESR is one example. Coagulation tests that require plasma, which would normally be our light blue top tubes, they can't be done on finger sticks. We don't even have micro tubes in the lab for those. There are some point of care instruments that do this, and there are some microtubes out there, but they're really not meant to do what we're talking about here. Blood cultures can't be done on finger sticks, and then any test that requires a lot of serum or plasma to be tested. So when you collect blood, it has to be spun down so that the serum or plasma can be tested. In most cases, sometimes they do test whole blood, but when you have to use serum or plasma for the test, it means you take the specimen and you spin it down. You're going to get just under half of whatever the specimen is. If you had 4 cc's of blood in the tube, only about 2 cc's will be serum or plasma. So if you need, 4 cc's of serum, you're not going to be able to get that out of a finger stick. It's just not going to happen. I went backwards somehow. There we go. The order of draw is not the same for capillary punctures as it is for venipunctures. And the reason for that is because we're not, with venous punctures, with regular old venipunctures, we are piercing the skin with a needle and we are putting the tubes on and off, and we're worried about reflux of the additive. That's why we have a specific order of draw. It has to do with the additives mixing together. When we're doing a finger stick, the blood is dropping right off the finger and into the tube. There's no needle. There's no chance for it to reflux back in. So when we are determining what order to collect them in for finger sticks or heel sticks, we have to think of something else. And what we consider in this case is how fast the blood wants to clot. So when we puncture the skin, it releases a chemical called thromboplastin, which activates the coagulation process, right? We talked a little bit about that back in chapter 8, I think, when we were talking about coagulation testing. So when you get a boo-boo, your body sends out a chemical that says, hey, we got a leak, we need to fix it. And your body starts scrambling the forces and getting them all to go to that spot where that hole is so they can plug the hole. They want to plug that leak. You only have a limited amount of time before the blood's going to stop flowing because the body's going to succeed at plugging up that hole. It's a small hole. So we want to make sure that we're collecting the specimens in the order that are least affected by, or most affected by clots to least affected by clots. So hematology specimens, the ones in our EDTA tubes, are going to be collected first because they're going to be most affected by the clotting process. So if we get any itty bitty teeny tiny microclots, things that you can't see, they would only be able to see this under a microscope, into your specimen because the body is forming those clots to try and plug that hole, that hematology test can't be done if there's any clots in the blood. So the hematology tests are the most sensitive to those clots there. Therefore, they'll be collected first. After that, we would collect any of our additive tubes, so green tops, gray tops, those kind of things. Things with that we don't want to clot but aren't as affected. And the last tube, and the last one in order, would be our serum specimens, so our gold or our red tops, because they're supposed to clot. They have clot activator in them. So it's less affected. Oops. Oh my gosh. There we go. So the technical blood order of draw for the blood is blood gas specimens would go first. So CBGs would be very first. Slides would be second. EDTA specimens would go next. All your other additive specimens, your heparin, your oxalate, that kind of thing. And then that would be followed by your serum, your clot activator specimens. All right. Generally speaking, you're not going to see slides and or blood gas specimens. You're just not going to see them. So most of the time when you're just talking in normal conversation, when you say what's the first thing in the order of draw, EDTA is what you're going to say first. But just so you know, technically, in your book list has two different lists. In one space it lists blood gas specimens, then EDTA, then the other things. And another place in the book it lists slides, then EDTA, then the other things. It never lists all of it together. So I'm listing it all together right here. This is the technical order. Newborn screening tests, those are PKUs. They should be collected separately. Every facility may have their own rules on this. Where I used to work, we collected those first, and then we did our EDTAs and stuff. I used to do EDTA, then the newborn screening, but technically they should be done in separate sticks. All right, so the capillary puncture steps, they're basically the same idea as what you do for a regular venipuncture. Okay, put on our gloves, we identify our patient, position our patient, we select our site. Okay, where do we want to go when we're selecting our site to do a capillary puncture? Okay, I'm going to show you a picture on the next slide. It'll show you where on the fingers. It's the middle or ring finger. It's like just off center and perpendicular to the grooves of the fingerprint. Like I said, I'll show you a picture of that. With infants, we want to do it on their feet. It's really on the sides of their heel, the medial or lateral plantar surface. We haven't done medical terminology, but medial means towards the center, lateral means towards the sides, plantar means bottom of the foot. If you remember make little people happy, you can remember that. We want to avoid areas that are cyanotic or edematous. And then here's the picture. Okay, so you can see on the fingers, that's the ring and the middle finger. And it's not quite in the center, it's kind of off-centered. And it could be going the other direction just as much as it's going in this direction. So the left or the right side, make a little V there. We want it to go against the fingerprint whorls, not with it. And then you can see this picture of the heel. So on the sides there, not in the center, not all the way up in the edge. And we'll be doing this in lab. And you can see this is how deep it goes down. This is where we want it to go, to about 1, but no further than 2. All right. So we warm the site. It works better. We clean it once it's been warmed. We don't use iodine because it can interfere with our test results. And we want to make sure the alcohol dries all the way because otherwise it can hemolyze our specimens and it'll hurt. We get all of our stuff ready. We grab our finger or our heel. I hold the lancet in my right hand and the person's arm or hand or foot or whatever in my left hand. All right. You give the site like a gentle squeeze, like really gentle. Then you're going to use, depending on how the lancet goes, some of them you use pressure to activate it in place, like you press down on the lancet. Other ones have a button. It doesn't really matter. However it goes, you want to make sure you're keeping it pressure on the device so that it stays in place and actually pierces the skin. You make sure you give them the warning, just like always. 1, 2, 3, here it comes, big stick, here we go, whatever. And then as soon as you're done hitting that button, it goes into the sharps right away. A lot of people have a tendency to set it down. You don't want to do that. You want to throw it right into the sharps. And you want to make sure you also throw it into the sharps, not the trash can. I guarantee you will throw it in the trash at least once. And then I'll make you put on gloves and dig through the trash, and it's not any fun. So then we want to lower the site and gently apply pressure. We're not really squeezing. It's more like milking a cow. We'll do this in lab. It's hard to describe in person without any visuals. We wipe away the first drop of blood because it's usually got excess tissue fluid in it, but it could also have alcohol. Every now and then you'll use a point of care instrument that requires the first drop, but most of the time we wipe away that first drop. And then so this is showing the puncture, getting a drop, wiping away that first drop. Then we're going to fill our tubes, okay? While we're collecting it, we can gently tap it to get the blood to settle and mix with the additives inside of there. There's fill levels on the tubes that are marked. So you fill your tubes, you put the cap on, you invert it. Once you're done, you're going to put gauze on, have them kind of hold it against their finger or their heel. Obviously, it's a baby. You have to hold pressure. If you can, elevate the site. You're going to label the specimen. Then you're going to check the site, make sure they're not bleeding, and put a bandage on. If the child is under 2, you're not supposed to give them a bandage. You're just supposed to hold pressure until it stops bleeding. And then once it stops bleeding, hold pressure a little longer, and then leave them be. All right? Otherwise, the rules are the same for, if the bleeding continues for too long and how long they should keep it on for. all this other stuff is exactly the same. There's a video in the book. If you go to the Point website from your book, there are some procedure videos for this, so you can check that out. So some special capillary puncture procedures would be the neonatal bilirubin collection. A neonate is just a newborn, all right? Bilirubin is a liver test, okay? It is, if you have someone that is jaundiced, it basically means they have too much bilirubin in their body, right? It kind of gives, like, it says yellowy, but like on newborns, they look kind of like almost like hot orange, pinkish in color. It's kind of goofy. There's a couple different reasons that it can happen. It's not that uncommon. And in many cases, like my son had a real mild case of jaundice when he was born. It wasn't really a big deal. They had to check his levels every now and then. But sometimes it can be serious. It just sort of depends. So we want to make sure that when we collect our specimens, we are collecting an accurate specimen so that that doctor can get accurate results and that baby can be treated properly. All right, so we have too much bilirubin in our system. They are generally placed under special UV lights to help break down that excess bilirubin. Bilirubin is broken down by light. I know when my son was born, he was only slightly jaundiced, so they didn't keep him in the hospital, but I was told to walk him outside as often as possible because that way the UV lights would help. All right, so since light breaks down the bilirubin, we do not want to draw our specimen under those UV lights. We want to turn off those lights when we go in to collect the bilirubin. This tube here you can see is amber in color. So when I talk about the amber colored tube, this is the tube I'm talking about. It prevents light from hitting that specimen. Sometimes there's amber colored bags. Sometimes you don't have an amber colored tube though, and you might have to use a regular tube, in which case you would collect it as quickly as you can, and then you would cover it either with gauze or Coflex or foil or put it in a bag, whatever. You also want to avoid hemolysis. You don't want to wreck your specimen because that can change the bilirubin levels. So if we have it exposed to light, the bilirubin breaks down and then the specimen isn't accurate, and that's not going to give the doctor or the patient anything good. The other special procedure is a newborn screening. You'll hear a lot of places just call this PKUs. All right. These are genetic, metabolic, hormonal, and functional disorders that can be detected really early and treated really early, and if they are treated really early, you'll have better health outcomes as a result. So you can see some information here. The reason it's called PKU is because of this phenylketonuria was one of the first ones. That is required by all states. And the thing is about PKU, here I'll go to the next slide, it's actually a defect in an enzyme that we all normally have that breaks down this stuff, which is in all food, and it converts it into tyrosine. If you can't break it down, it actually accumulates in your blood and your brain, and it will eventually raise the toxic levels and will lead to brain damage, which then leads to mental retardation. The thing is mental retardation isn't always very visible in kids until they're about 2 or 3 years old. So if you didn't know your kid had PKU, had this issue, and couldn't break down this stuff, you're going to feed them regular food, they're not going to be able to break it down, and then they're going to have this toxicity, and it's going to lead them to be retarded. You're not going to be able to detect they're 2 or 3 years old. By the time you notice, it's irreversible. That child is always going to be forever mentally handicapped. If you could find out when the child is days old that they have PKU and can't break this stuff down, and then begin treatment and change their diet and do all this other stuff so that they never ever have this toxic level of PKU in their body, they'll never have brain damage and they'll never have to worry about mental retardation. So in some of these things, it's not like, in this case, it's totally like we could prevent the negative outcome. Some of the other diseases, it's not something we can completely prevent, but we can manage it much more effectively. Like hypothyroidism, galactosemia. So there's a lot of different things that can be treated. Cystic fibrosis is another one. We can't prevent that, but we can certainly change the way that the person, we can extend their life expectancy, reduce respiratory distress and malnutrition. Okay, so the sooner we get this stuff, the results of these tests in, the better. So usually we collect these between 24 and 72 hours of age, although newer state rules allow testing as early as 12 hours old. Where I used to work, I remember it changed from 24 hours to 12 as long as the baby had had one full meal. And we get this special paper, and I've got some pictures on the next slide of it, and they got circles on them, and you're supposed to get one big nice drop right into the center of the circle, and the circle has to be totally filled, and the paper has to air dry. All right, so on the next slide you'll see this. So that is 1 drop of blood, and it can overfill the circle, but you don't want it underfilling the circle. These used to be hand punched, but it's been many years now. This little piece of paper with the circles on it gets ripped off, goes in a machine, and a machine punches some little holes out of this thing. So if your blood drop isn't centered, it's not going to punch out in the right place. You have to have 2 or 3 like perfect ones, so they give you a few extras. The thing is, if I collect this at 12 hours and then I'm going to set it out to dry, it's got to lie flat, it's got to dry, it's going to take several hours for it to dry, then we ship it off, and then they test it, and then we get the results. If we've done everything right and it doesn't need to be recollected and we didn't have any delays on anywhere else, everyone did what they were supposed to be doing, we should have, at the hospital, we should have results on this test before the baby goes home, which is extra important because in a lot of cases, the baby, I don't say in a lot of cases, in some cases, the parents do not have health insurance, or maybe they have health insurance, but they don't actually have any money to go to the doctor. They don't have, for whatever reason, they don't have access to good health care. They're not going to be going. And so even though they might list a doctor, which we might call with these results and say, hey, baby Susie has PKU, if that patient never brings that, if the patient's mother never brings that baby into that doctor, they're never going to know. So ideally, we want to make sure that these people are getting the results before they even leave the hospital. And most people, when they have a baby, stay in the hospital for about 48 hours. So we've got some time to get these results to them. I have seen it at work where people collect a PKU. They know it's a crappy job. They still set it on the drying rack, and then we don't find out that it needs to be recollected until it comes down to the lab and we're getting ready to mail them. And we look at these cards and we're like, who the hell collected this? And we know exactly who collected it. And we're going to tell them, hey, if you know you had a crappy collection, you should have had another phlebotomist go up there and get it. So these things happen. I love PKUs. Most people hate PKUs. They're hard to do. I think they're great, personally, but I also practice a boatload at them. It just takes practice. You just have to be willing to get in there and try them over and over and over, and not be afraid to stick a kid. So, but anyway, here's the case study. Here's the case study questions. We'll do those in class and some answers, and that is the end of the show.